The average person will spend more on prescription medications than anything else in healthcare expenses today. Now, Medicare Parts A, B, C, and D do cover medications, but they cover them differently. And unless you are taking a covered immunization, there will always be a cost to you. That could be as little as a few dollars, upwards to a few $1,000s. In this video, we're going to look at the 10 most popular low-cost generic medications, as well as the 10 most popular brand name expensive medications, so that you'll know exactly what they're going to cost you in 2024. All right, so let's take each part of Medicare, A, B, C, and D, and break it down to show you what those parts will cover and your out-of-pocket costs. First off, when it comes to Medicare Part A, this is the inpatient, or what's called the hospitalization side of Medicare. And so as far as medications covered under the Part A, it's going to be anything that you would be prescribed while you're being treated during an inpatient hospital stay. Again, this is in the hospital under observation. This means you're admitted. So all the meds covered during that time are going to be paid through the Part A system. Also, skilled nursing facilities. So this is someone that is admitted for inpatient rehab. This is typically after about a 3-day or longer stay in the hospital. We go to skilled nursing. This would be after a stroke, maybe a knee replacement, maybe an injury accident or something like that. But anything that's administered while you're in that skilled nursing facility, again, is going to be paid just like the hospital meds are paid through A. So will the skilled nursing facility meds be paid through Part A. And then also hospice. When someone's been diagnosed with a terminal illness or an illness where they're going to need hospice care, then the meds that are administered during that hospice care, which is typically for pain management and those types of things, are going to be covered through the A system. So let's talk specifically about the cost. So if I'm in the hospital, what happens in original Medicare, we have what is called the A deductible. The A deductible for this year of 2024 is $1,632. $1,632. Now, what that means is that you have to pay $1,632, and then Medicare is going to pay everything. So what this means is anything between 1 to 60 days in the hospital, which is a long time, all the hospital bills, that would be nursing services, room and board, any tests that you have during that time, as well as medications, are all going to follow under that particular deductible of $1,632. Now, if someone happens to be in the hospital longer than 60 days, what happens is Medicare starts charging daily copays for the next 3 months. So what we have here is, this would be month 3, we'd be responsible for a $408 daily copay. Days 91 to 50, which is month 4, and month 5, it doubles to $816 a day. But my point is this: if someone has these extended hospital stays, they're responsible for daily copays. And again, everything that's happening in that hospital, whether it's a test, nursing services, room and board, and medications, would be paid under that daily copay. All right, and so that's going to be the A for the hospital side. Now, the skilled nursing facility, remember, this is nothing more than inpatient rehab. Someone needed rehab, and they needed the intensity of being in a facility every day so they can have continuous care. So here's the way this works. Medicare says while we're in the skilled nursing facility, for the first 20 days, there is no out-of-pocket cost, including medications. As long as we had that 3-day hospital stay prior to going to skilled nursing, Medicare covers everything. But then after that, what we have, days 21 to days 100, we have a daily copay this year of $204. $204. And that $204 is a daily copay. So what does that mean? From days 21 to 100, any care I'm getting, including medications that I'm prescribed, are going to be covered by that daily copay. Now, when it comes to hospice care, again, this is someone that's been diagnosed typically with a terminal illness, 6 months or less to live. So here's the way this works. Hospice care, for all the medications that you take, and again, they're going to be primarily pain management, those types of meds, it's going to be a $5 copay for any medication that you need while under hospice care. Now, it is not uncommon for people to have just maintenance medication, maybe cholesterol or a blood pressure medication or whatever they're taking, could be insulin, while they're on hospice. Then those would continue to be paid through their Medicare Part D plan, or if they're on a Medicare Medicare Advantage plan. That Medicare Advantage plan has a prescription drug component within it, and all those normal maintenance meds would be covered by the Medicare Advantage plan. So this is Part A, medication costs and coverage. All right, now let's go to Medicare Part B. And what you're going to see as I share this with you, you're going to notice that in both Parts A and Part B, when they're paying for these meds, these are all professionally administered medications. Those were given to you by a doctor or a specialist or an anesthesiologist in the hospital or some type of an outpatient setting. All right, so Part B, what they're going to cover first off would be things that are injectable, infused drugs. These are oftentimes also called biologics or biologicals. And so this would be any medication that, again, that is, you're not self-administering, it's being injected either in a doc's office, outpatient clinic, those kind of a settings. Medicare Part B is going to pay the cost for that. Also, insulin that's used with the insulin pump. And this would also apply for any medication that's used with any kind of a durable medical equipment. Insulin pump is called DME. A nebulizer would be DME. So anytime we're using a durable medical equipment that's approved by Medicare, any medicines that are in that durable medical equipment are also covered by the Medicare Part B. Now this just changed in 2023, and that is the maximum Part B cost on any kind of insulin on B or D would be $35 for a monthly supply. Okay, and so what we have is we just have a flat copay now on covered insulins, and of course those would be that are going through the insulin pump. In addition to that, also oral cancer medications. Now again, these aren't self-administered. This is something like a chemotherapy pill that you may take in a facility, and then anti-nausea drugs, obviously for the treatment of cancer. So if it is approved to be paid by Part B, whether professionally administered or self-administered, then it is the B system that's going to cover that. So let's just pause for just a second and let's talk about Medicare Part B and the cost. And I'll just show you a couple more items. When we have Medicare Part B, we have to pay a premium. The premium for Part B for 2024 is $174.70 a month. Now that's if you're a single person who makes below $103,000 a year, a married couple that makes below $206,000 a year. You would only pay the $174.70. Now if you're above 103 as a single, 206 as a married person, then you have an additional amount that you're paying for your Medicare Part B. Those are called IRMAs. So as we talk about the cost, want to make sure that we know that includes having to pay for our Part B premium because these things are going to be covered under the Part B of Medicare. All right, and so what we have in original Medicare, once we've bought our Part B premium, what we have is all the bills are going to be split 80-20. So Medicare is going to pay 80% of the bill. You're responsible for 20% co-insurance. So again, if I have an injectable infused drug, once I paid my Medicare, I just have to meet then a deductible, which this year is $240. So I've got to meet my deductible. And again, this is just once a year and that's it. So once I've met that deductible, then Medicare pays 80% of these drugs and I'm responsible for 20%. That would be co-insurance. And when it comes to oral cancer and anti-nausea drugs, the same thing is going to apply. If I've already met my deductible, I don't have to worry about that, but then I'd be responsible for 20% co-insurance. Now, there are a lot of people, what they're going to do is they're going to actually buy a supplemental plan to cover that 20%. In fact, if you buy a supplemental plan G or you buy a supplemental plan N, these are the top two plans today as far as popularity, that G and the N plan would cover that full 20% for you. But if someone did not have a supplemental plan, they had A and B only, which is very, very risky, then they would always be out of pocket that 20%. All right. Now, in addition to that, we also have end-stage renal disease. So this is someone that's been diagnosed with a kidney failure, stage 4 typically, and they are either awaiting a kidney transplant or they're on dialysis. And so all the medications that are going to be necessary for the dialysis treatment then are going to be covered through Medicare Part B. So if they want excellent coverage, what will they do? They'll buy a supplemental plan G or N so they don't have to worry about the 20%. But if they don't have that supplemental plan, once they've met the deductible, again, they're going to be responsible for 20% of those costs. And then lastly, we have immunosuppressant drugs. Not lastly, one more item here, but immunosuppressant drugs, this is someone that's had a kidney transplant. and they're on Medicare. So the drugs that they need for anti-rejection are going to be covered through the Medicare B system. Now, there's one thing that's very interesting about these kind of drugs. Many people that have a kidney transplant are possibly going to have that transplant prior to turning 65 and being eligible for Medicare. So what happens, let's say someone has a kidney transplant and they're 50 years old. And Medicare puts them on Medicare because of the kidney transplant. But what happens after 3 years, they are going to lose their Medicare coverage unless they have a disability. But just the average person is going to lose coverage after 3 years. So what Medicare did starting in January of 2023 is they came up with a separate plan, which is called for Medicare Part B, immunosuppressant drugs. And so what happens is now someone that doesn't have any other kind of insurance options, such as a group plan or a work plan, then they can go out and they can actually buy just drug coverage alone. This isn't all of Part B that would be covered by someone normally on Medicare, which would be outpatient surgery and home health care, durable medical equipment. This is not for that. This is just for drugs. So this is someone, again, they've lost their Medicare eligibility because this 3 years has now expired. They can buy a plan to cover these immunosuppressant drugs. But why? Because they're very expensive. And the government wants to make sure you can get those meds. So what they have is they have a premium that has to be paid. In 2024, that is $103 a month to be able to get those immunosuppressant drugs covered. And by the way, that's a bargain. Now, just like up here, if you're high income, you could have an IRMA. There could be something additional. But as long as we're below 103 or below 206 as a couple, then you would just pay that premium for those immunosuppressant drugs. And again, in this scenario, what are you responsible for? You're responsible to meet the deductible once a year and then 20% co-insurance. All right? And of course, here, you wouldn't have a G or an M plan because you're not in the Medicare system. So you'd have to pay that 20% co-insurance. All right. And then lastly, I do want to talk about vaccines. And so the way vaccines work is that Medicare actually covers some vaccines under Part D. They also cover some under Part D, which we'll talk about in just a minute. But I want to distinguish this because Medicare for years has covered some vaccines, and they would cover a pneumonia shot, the flu shot, hepatitis B shot, and then when COVID hit our country, they began to cover COVID shots as well. And all that was covered at no cost under Medicare Part B. All right, so one of the real difficult situations for a vaccine was the shingles vaccine, because the shingles vaccine, which is Shingrix, usually taken in a round of 2 shots, was not covered under Part B. It was covered under Part D, but it was subject to cost sharing, deductible, a copay, co-insurance possibly on the shingles shot. So in January of 2023, part of the new legislation, now the shingles shot is a no-cost immunization, but it's not covered under B. It's not going to be covered under the drug plan. In fact, any adult immunization that's been recommended by Medicare then will be covered either by Part B or Part D at 0 cost to you. All right, so that's the way the Part B side of Medicare is going to work for those types of medications. All right, so that then brings us to Part C as well as Part D. And so let me kind of explain what I'm saying here in this. If you have Medicare Part C, these plans are called Medicare Advantage plans, Medicare Advantage. Now, when someone has a Medicare Advantage plan, they have it in one of 2 ways. They have what is called an MA-only plan, which is Medicare Advantage only, meaning it's just for inpatient and outpatient, or they have what is referred to as an MAPD. And you can see Medicare Advantage part is inpatient, outpatient, hospital and outpatient care, and PD is a prescription drug plan included. Now, the only people that should have an MA-only plan will be those that are able to get their medications through some other type of credible drug coverage, which would be the VA, TRICARE. If you're retired military, you have TRICARE insurance, or if you're retired from the federal government, you have FEHB benefits. Those 3 groups of people, VA, TRICARE, or FEHB, really, and also sometimes employer plans as well that are retiree type plans, you could get by with an MA-only plan. In fact, they're very, very attractive. Why? Because you're getting your medications through another source. But the majority of you are not going to be eligible for one of those programs, so you are going to absolutely include a prescription drug plan within. So you have what's called an integrated drug plan. You have your Medicare Advantage plan that is included within that Medicare Advantage plan, a Part D plan. So that's one way we can get them covered. Another way, you'll notice up here, standalone. Sorry for the typo there, it should be 2 words, but standalone. And that just simply means we have a separate drug plan, separate. So what this means is whenever someone decides to stay in original Medicare A and B, they normally get a Med Sup plan to fill in the gaps, financial gaps that Medicare didn't cover. And then what we do is we add also a Part D plan for our self-administered prescriptions. So we have this. So I have a premium for my A and B, I got a premium for my SUP, and I got a premium for my Part D plan. All right. And so what we're going to talk about now, we're going to talk about how the standalone Part D plans work, or if I have an integrated prescription drug plan with my Medicare Advantage, what are they going to cover, and what will be the cost of those medications. Hey, if you found this video helpful and if you want to see more Medicare information just like it, then go below, right below the video, and you can give us a thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. Now, just before I get into the cost, I want to show you some of the components of every Part D plan, whether it's standalone or it's an integrated plan. We're always going to have some kind of a formulary. In fact, the formulary is the most important thing that we look at when it comes to picking a drug plan. Why? Because this is the list of the medications that are covered by the plan. Some plans are going to have anywhere from 2,500 to maybe 3,000 meds, and others may have as many as 4,000 medications. So we look at the formulary, the list of meds that are covered by that standalone plan or integrated within the Advantage. Secondly, every drug plan is going to have one of 2 types of pharmacies. Either its pharmacy is going to be rated as what we call a preferred pharmacy, or it's going to be a standard pharmacy. Now, what this means is that the preferred pricing is going to be better. And so one plan may identify, let's say, Costco and Walmart as preferred pharmacies, everybody else standard. Another plan may say a CVS and maybe a local grocery store, preferred pharmacy, everybody else standard. And the point is they're going to identify 1 or 2, maybe 3 pharmacies that give you better pricing than all the rest. And so it's always wise, if you can, to better get your prescriptions at a preferred pharmacy, because sometimes there's a substantial difference in the copays on those. Thirdly, what we have some utilization rules, meaning some management tools that all Part D plans can utilize to be able to control their cost. And one of the biggest ones would be what's called quantity limits. Quantity limits, that means that Medicare says with some meds, either addictive meds or expensive meds, there's only can be so many pills in the bottle. They'll say we'll allow you to, 1 of those a day. So if it's a 30-day fill, there's 30 pills in the bottle. If it's a 90-day fill, there's 90 pills in the bottle. Those are called quantity limits, and you just have to live with the rules of that. Secondly, what happens, Medicare has a thing that they call step therapy. Step therapy, again, a management utilization tool, because there's a lot of expensive meds that are brand names, but those brand names sometimes are going to have generic alternatives or generic equivalents. And so what you may have to do is you may have to try the generic lower cost medication before you can step up to the brand name. Now, if doctor says you've tried those lower cost medications and they're not effective, they don't work, there's a problem, then many times that plan will give you an exception for step therapy, and we'll go ahead and fill the brand name medication. But for that to happen, your doctor is going to have to be involved. And then lastly, we have what's called prior authorizations. Prior authorization means, again, a med that's normally very expensive, and so the doctor has to justify why this is being prescribed, what's your condition, why this is the medication that needs to be taken. And so, again, the doctor is going to be involved in that, and usually those plans are going to approve it, but they're not going to fill that medication until you've gone through that prior authorization process. All right, and then also we have switching of plans. And this is one of the good news about drug plans, because frankly, sometimes people they may be taking 5 or 6 meds now and their health gets better. Now they're only taking 1 or 2, or maybe they were doing great and they had a serious health issue and now they're taking 6 or 8 meds, where before maybe they're taking none. And so now we can switch drug plans, whether we are taking more or less, or there's been something that's changed with their plan that's no longer in our best interest. And so what happens is standalone drug plans can be changed every year, if necessary, between October 15th and December 7th. So those are the dates, about 7 weeks, and those standalone drug plans that are picked out would go into effect January 1 of the next year. Now, if you have an integrated drug plan within your Advantage plan, you actually can change those twice. We have the same dates, October 15th through December the 7th, but then also January 1 to March 31. And so you can actually change your Advantage plans anytime. Now, if I do them anytime during these months. So if I change my Advantage here, my new drug plan will go into effect January 1. if I do it the first quarter of the year and I make the change in January, my new plan will go into effect February. If I switch in February, it goes into effect March. Switch in March goes into effect in April. All right, and so we can switch drug plans if our health changes or circumstances changes with our plan. And then lastly, I'm going to conclude with this. I'm going to talk about the different phases, and then we're going to get in. I'm actually going to show you the different cost in these phases when it comes to prescription drug plans. So let me just give you just a quick illustration. Those of you that are still working and covered by an employer plan, or those of you that are covered by an individual plan, what you have right now is you have a one-phase plan, and that means that the medications covered by your individual plan or your group plan, they normally will give you a tier number, and with that tier number is established a copay, and that copay is the same amount all year long. It never changes. It's a fixed copay. But when we go on Medicare, at least for this year, there are still 4 different phases. Now, this is going to change in 2025, but for this year, we still have 4 phases. So that just simply means that our copay on one medication can actually change out-of-pocket expenses to us 4 times in the same year. So again, employer plans, individual plans, 1 phase, Medicare plans for at least for this year, 2024, 4 phases, into 2025 thereafter, it's just going to be 2 phases. So let's look at the phases. So let's look at the details of these 4 phases and how we actually move through the phases. So first off, the deductible phase is a deductible that's established by Medicare. This is $445 a year for 2024. Now, there are some plans that actually reduce that, some even bring it down to 0, but the majority of them, you're going to be responsible for a deductible. And all that simply means is the full cost of the medication, the retail cost, would be your responsibility until you hit the deductible. Now, a lot of people, their meds are so cheap or they're deductible exempt where they never even meet that deductible. So if we don't meet our deductible, then we just simply stay in phase 1 the entire year. You don't move on. But if we do meet it because we have lots of meds or expensive meds, once we've paid that $445 out of the pocket, that moves us into what is called to the initial coverage phase. So here's what happens in this particular stage. You, as the enrollee, or what I'm calling the patient over here, you're responsible for 25% of the cost of your medications. And then that Part D plan that you bought is going to be responsible for 75% of the cost. But what's happening in this particular stage is something very unique to Medicare, and that is Medicare is tracking the full retail cost. Full retail. You're not paying full retail. You may have here the $545, but here you just pay 25%. But they're tracking what you and the plan are paying during these 2 phases. And so if that number ever hits a certain number, that this year in 2024 is $5,030. This is called the retail threshold. Now, the majority of you watching this would never reach that with retail costs. Some of you will because you're on either lots of meds or expensive meds. But if I never reach the retail threshold of $5,030, I will finish out the year in this stage 2. And again, that's where most of you do. But those of you that are on lots of meds or expensive meds, if you reach that, whether we reach it in April or July or November, but if we reach that retail threshold, we're done in stage 2, and that moves us into what is called the coverage gap, or what we refer to as the donut hole. Right? So in the donut hole, again, we're talking about different responsibilities. What happens is you, as the enrollee or the patient, you have to pay 25% of the cost of those medications, the retail cost. And then what happens is we got the manufacturer over here that's actually going to give you a 70% discount on those medications. So they participate in, then the Part D plan has to pay the remaining 5%. All right? So that's how we're going to get to the full retail cost. So out of your pocket, this is what matters. But what's going on in this particular phase, just like we had a threshold here, we have another threshold called the true out-of-pocket. And this year, that is $8,000 even. $8,000. Now again, that's not out of your pocket because the manufacturer over here had to discount that medication 70%. So if you're on a medication that retails for $1,000, that costs you $250, but the $700 discount was also applied to that true out-of-pocket. So this goes in and this goes in into that number plus everything else that you have spent. All right, so what they say now is that anyone who actually gets to the donut hole in 2024 will spend no more than about $3,300 out of pocket. By the time you paid your deductible, your 25% coinsurance, your 25% here, you got that 70% discount, you're going to spend about $3,300 for the year. And then we go to phase 4, which this year, 2024, is zero. Part of the Inflation Reduction Act said that we would eliminate the catastrophic irresponsibility of copays once you got there. In 2023, this read 5%, but in 2024, it's been eliminated. So once we have met, again, this total number here, then we'll have no additional out-of-pocket expenses. Now, let me just real quickly show you what's going to happen in 2025, because it's even going to get better. So what's going to happen in 2025, we have a $540 deductible, so went down a whopping $5. But then what happens when I get to this initial coverage phase is this. I'm going to be responsible for 25% coinsurance. And what happens, though, in this phase in 2025, the manufacturer's got to give me a 10% discount. The Part D plan is going to cover 65%. But here's the beauty. My 25%, plus if I had a deductible, I now have a cap of $2,000. I will not spend any more out of pocket for the whole year than $2,000. So that's why we're saying in 2025, there is no donut hole, and really catastrophic is gone as well, because that's the cap, that $2,000. And Medicare is working on implementing a way where this $2,000 didn't have to be paid, all one lump sum. You're actually going to be able to spread that out. We don't have the details on that, but they're going to make it very smooth for people that have expensive medications to spread that $2,000 out throughout the year. Now let's look at those 10 medications that are most popular for generics and most popular for brand names, and let's look at those costs. Hey, Medicare can be very confusing. In fact, people make mistakes all the time because of how confusing it is. So what I've done is I've actually created a Medicare, notice this, Essentials Workshop, where you have the opportunity to really learn everything that you need to know about Medicare so that you can make Medicare decisions. There are thousands of people every month that watch this workshop, and we get lots of reviews saying that this is something that really was helpful to them. And so what you can do is down here below in the comments section, you'll see where it says pinned comment. At the very top of those pinned comments is a link. And you click on that link, what we're going to do is we're going to give you free access to this Medicare Essentials Workshop. And we want you to watch it because we don't want you to make any mistakes. All right, so these are your top 10 as far as popular generic medications right now. So what I'm going to do is show you, first off, 3 very common high blood pressure medications: amlodipine, lisinopril, and losartan. Now remember, we have these different phases, so that's why the retail cost matters. Why? Because remember, that retail cost is still going to be tracked this year. So if my retail cost ever gets to $5,030, then that's going to put me then in the donut hole. All right, so that's why retail matters. And so if I ever reach that $5,030, then I will be in the gap and we'll have a different copay. So notice, again, very, very low cost. The total retail cost on those medications, $1.15, $1.45, so very, very low out of pocket. When it comes to a couple statins that are very common today, atorvastatin, which is generic Lipitor, rosuvastatin, which is generic Crestor, again, very, very low retail cost. And then we'll look at a couple more. Omeprazole, this would be for acid reflux, again, very low cost. Gabapentin, this would be for nerve pain, sometimes for other issues, but typically nerve pain. And then we have metformin, which is for those that either are pre-diabetic, type 2, or actually have type 2 diabetes. Then that's going to help them with their sugars. And then number 9 would be levothyroxine. Someone has an underactive thyroid, oftentimes will take levothyroxine or Singulair, which is a brand name. And then number 10 would be albuterol sulfate. This is an inhaler, ProAir or Ventolin, those kind of inhalers that we use for either for asthma or possibly a mild situation with COPD. But here's what I'm trying to show you. And all these medications, you're going to notice what the retail cost was. And by the way, in this situation here, the levothyroxine, I'd be using a GoodRx coupon if it were me anyways. But the retail cost only matters as it relates to what I'm going to have to spend out of pocket initially. And then also, will I ever get to the gap? And as you can see, with all these medications, there is no way you're going to reach that retail threshold of $5,030. So if I'm even taking all these generics, I will never reach the donut hole in 2024. Well, then what I did is I put all these into a plan formulary that we have that looks at all the different drug plans in a given area. And so what I did is I found a plan that literally costs 50 cents a month premium. 50 cents a month, all right? And so on that plan, you're going to notice that many of the medications were a zero copay. Now, when we got down here to gabapentin, it had a $5 copay, and then the albuterol sulfate, that Ventolin, had a $6.98 copay. So this was not what I spent out of pocket. This is actually on that Part D plan. These were my actual copays. So as you can see, less than $12. And I got that plan for 50 cents a month. And that's why we tell people, even if you take generics or even no meds, you want to get some type of drug plan just in case. All right, now, what pushes us into the gap is that $5,030. Clearly, we're not going to do that with these medications. But if I did, in the gap, what do we have to pay? We got to pay 25% of this retail cost. That's my gap. And you can see, again, those are also pennies as well. But again, we'll never get to the gap because of the generics we're taking. We're going to get to the gap, if we do, because of those expensive brand names. Let's look at those next. All right, these are your 10 most popular brand name medications that are taken among the Medicare clientele. All right, the first couple are going to be blood thinners. Some of you are on these, would be familiar with this, of course, but Eliquis and Xarelto manufactured by different companies, but very similar in that they're blood thinners to help treat blood clots or prevent blood clots in the lung or in the legs. Now, Eliquis is normally a 2-day medication, Xarelto usually 1. Again, they're different. Some would say the Eliquis may be a little bit more safer, a little bit more effective. And by the way, I'm no doctor, not trying to pretend to be. I'm just trying to say, as we work with people and we find out the difference between these. But this would be 1 a day, 2 a day. Here, Eliquis, again, a lot of tests have proven that it may be more safe or more effective. Xarelto would be for people that would have an AFib, as long as they don't have any kind of heart valve issues, then Xarelto is prescribed for them. And so the whole point is blood thinners. You're going to notice, because they are patented and there's no competition with these medications, they are going to be very expensive. We have a retail cost of $540, $520. Now, why does that matter? Well, if I have a deductible very quickly in one fill, I'm going to meet that deductible. Remember that phase 1. But also, it's that retail cost that if I ever reach $5,030 in the year, that's going to put me over here in the gap where my copay is going to go up. So remember what I said? Once we get to that $5,030, so let's say that's all I was just on Eliquis alone, I'm going to get there in a little bit less than 10 months. It'll put me in the gap, and then my copay goes to $135. All right, so let's say that I meet my deductible because I have to on Eliquis, $540, and then that was going to happen in January, and then February, March, April, May, June, July, August, September. Within about 8-9 months, I'm going to reach that $5,030. It's going to put me in the gap, and then my copay is going to go up to $135. Now, what they're tracking here was that true out of pocket. Remember that $8,000 number is tracked. 70% of that number has been a manufacturer discount. But if I did go get through the gap, $8,000, which you wouldn't if you just took Eliquis alone, but if I did, then I'm going to be at a zero copay, because remember, in 2024 on, there is no catastrophic coverage at all. So the whole point is this: I'm going to change copays based upon what phase I'm going to be in. Now let's look at a couple other examples here. These next ones are all going to be diabetic medications. Januvia, Jardiance, most of these are for type 2 diabetes. Some of these would be for those that have not just type 2 diabetes, but also maybe some cardiovascular issues. So this could be help with the heart, sometimes even with the kidney as well. And so, but these ones right here are just going to be for really type 2 type of people. Lantus is an actual insulin. These here, again, for people that still have type 2, they're still producing some insulin typically, but they may just need some help with their pancreas. And so the point is, you're going to notice that all these medications are also very expensive from a retail standpoint. Look at that Ozempic medication now that some are taking, not only for diabetes, but they say it helps with weight loss as well. But again, the retail cost matters. Why? Because if I hit that $5,030 number, it's going to put me over here into the donut hole. All right, so again, Lantus would be a long-acting insulin. Okay? So this is going to be a true insulin, and because it's a true insulin, notice what the copay is. $35. Never subject to deductible, $35, okay? And then again, when we get over here, and even if we got to catastrophic, we have a $35 flat copay, because the Inflation Reduction Act said that now the maximum copay on an insulin that's covered by the plan, because they all don't have to cover them, but if it's covered by the plan, then the maximum copay in all the stages would be $35. $35, and nothing that here would be subject to the deductible. All right, now let's look at another very common medication today, which is Humira. And this is going to be for autoimmune diseases, psoriatic arthritis, those types of things, rheumatoid arthritis. People that take that, very, very expensive. You'll see $8,100 on a retail basis. All right, that brings us into number 9, which is called Imbruvica. And this is, again, a self-administered oral medication for cancer. People with lymphoma or leukemia oftentimes would take this either to stop the growth of it or slow down the growth of it. And again, you're going to notice here it has a very high retail cost. And so you'd have a responsibility, of course, to meet a deductible if your plan had that. And then before the gap, this would be your co-pay. And then we get into the gap, which of course wouldn't take but about a month and a week or two to be able to be into the gap. But then again, once you got to the gap, you'd be responsible for that. But remember what I said earlier, the most you're going to spend in this for this medication, if it was all you took, would be that $3,300, because once we get to that $8,000, we're into the catastrophic phase, and then there's going to be a zero copay after that. So again, we're talking about a medication that retails for $6,600. We have to pay for half of 1 month of that. And that's why it's so important to have a prescription drug plan if you got on a medication like that. All right, and then I want to look at the last number 10 of the most expensive, and that is Revlimid. And Revlimid is a cancer medication that is for people who have been diagnosed with multiple myeloma, typically cancer, white blood cells, bone marrow, those types of cancer. So it's used to, again, slow that or to stop that. And again, you can see on a monthly cost, $29,000. And so what's going to happen on this medication? Well, again, with just one fill, even before one fill, we're going to quickly get through all the phases and eventually get down here to zero. All right. And so what's going to happen here, if I'm on that Revlimid, I'm going to be spending $3,300 in that fill. I've gone through stage 1, 2, and 3, and I will be at a zero out of pocket from then on out. So again, you can see that's why, again, we encourage people to get a drug plan. You can get a $29,000 medication that would be monthly, which would be what, $350,000 for the whole year. You get it for $3,300 for the whole year instead if you have a prescription drug plan. Now, as I looked at drug plans for all of these meds, and again, you would not necessarily have to be on this one, but I found a plan, and all these medications were covered in formula by a plan that was $106.70 a month. But again, if you could get $29,000 medication per month, a monthly cost, and get it for only $3,300, you'd gladly pay for a prescription drug plan that costs $106.70. And I'm not implying that everyone would have to be on that kind of expensive drug plan, but when I put in the formulary and I shared all these specific medications, this is the plan that came up, and all of them were covered. So the most anyone would spend out of pocket for all these medications would be $3,300 for the entire year. That's the benefit of having a Part D plan.